Hello, my name is Gavin. I'm one of the consultant radiologists here in NHS Tayside. I will explain a little later on what a radiologist is as we go through this, but what I'm hoping to do today in this audiovisual presentation is to describe what the radiology is in the detection of cancer, in the confirmation of diagnosis, and how we use the images that we get to plan the best treatments for patients that ultimately get diagnosed with cancer. There are three main radiology departments across NHS Tayside. They have similarities but also have differences. The similarities are that patients come either as inpatients or outpatients for imaging investigations, and the imaging modalities, that's the kind of machine that we use to produce the pictures, varies a little between the different sites. Inevitably, there are quite a lot of words that might be new to people who are not familiar with X-ray departments, and also it is useful that people know who work in an X-ray department. The work of a radiology department is largely a team activity. Patients are referred for imaging investigation, usually by doctors, but increasingly by specialist nurses or other people working in clinical pathways for the care of patients. Patients are referred usually in the process of trying to make a diagnosis to explain what is going on with them, to explain their symptoms if possible, and then following on from that, imaging is used to guide the best treatment regardless of what the disease is. Quite a lot of the imaging that goes on in an X-ray department may well involve cancer, as imaging is very useful at detecting cancer and has a strong and increasingly powerful role in determining what is the most effective form of treatment. Most of the images in a radiology department are reported by a radiologist. A radiologist is a doctor who, after a period of initial hospital training, has undergone a prolonged period of specialist training in radiology and will have sat and passed exams to become a qualified radiologist. The main role of a radiologist is to make sure, as much as possible, that patients have the best imaging modality for what their problem is. But beyond that, to make sure that the imaging is done to the maximal effect, and then to take the information from the imaging and turn this into a clinical report to send back to the referring doctor to provide as much information as is possible from the imaging to guide diagnosis and management. Radiographers, on the other hand, are specially trained technicians who during the course of their degree training have a good understanding of how radiology equipment works, how to use this safely and effectively, and again to produce the most optimal images to allow diagnosis and care of patients. Other people work in the X-ray department too. We have clerical staff who are involved in making appointments. We have clerical staff who look after the issuing and recording of reports. We have imaging department assistants and helpers who help the patient through their examination, and, of course, our inpatients require the help of porters to come and go from the X-ray department. You will hear people speaking about different imaging modalities in the X-ray department. An imaging modality is a description of the kind of machine that we use to take the images, and obviously this affects the kind of pictures that we get. A plain X-ray is just a simple X-ray where X-rays from the X-ray tube shine through a part of the body and we get a picture created by the shadows of the rays that come through the patient. We have CT scanners, which are a bit more sophisticated but still rely on X-rays passing through a patient. CT stands for computerized tomography. Images produced by a CT scanner are displayed as slices. These can be axial slices, which are across the patient, or these can be sagittal images, which are slices produced from side to side, and also coronal images, which are slices produced from back to front. Ultrasound images don't use X-rays, they use sound. People are often more familiar with the use of ultrasound in evaluating unborn babies in the mother's uterus. Ultrasound is used in X-ray departments mainly to look at solid organs within the abdomen or pelvis, such as the liver, the spleen, the kidneys, and so on. It can be used to look at joints, muscles, and can also be used to evaluate lumps under the skin. Another modality is MRI, which stands for magnetic resonance imaging. An MRI scanner is a scanner that looks quite like a CT scanner in as much as it has a round hole that the patient goes into, but it produces its images using high-powered magnetic fields and radio waves to look where the protons are in the body and to see what molecules the protons are in. Each of these modalities has its own terminology, but some of these words are common to all types of imaging modality. For example, the word contrast describes what is black, white, or a shade of grey. Contrast produced by a CT scanner will be different from an MRI or ultrasound scanner, so that what is black, white, or grey will be dependent on the modality used. Contrast enhancement involves injecting a fluid, getting the patient to swallow a liquid, or putting something into the body to alter the body's natural contrast. For instance, in CT scanning, these are commonly performed while the patient is getting an injection of iodinated contrast, which then appears as white wherever it is in the body. So, that is a little bit about who works in the radiology department, what we do in a radiology department, a little about the modalities that we use, and some of the terminology involved. What I want to do now is spend a little bit of time introducing what the radiology input is to the detection of cancer, and more particularly what the role of radiology is in the multidisciplinary team meetings, or MDTs, that exist for each of the cancer sites. When we are speaking about cancer sites, we mean the location in the body affected by the cancer. Radiology has a key role in detecting cancers, and often this is at the simplest level of demonstrating a lump or blob of unusual tissue in some part of the body where we don't expect to see it. An obvious example of that would be to use a chest X-ray to detect a lung cancer, which might appear as a rounded white blob in the lung where nothing like that would be expected. Cancers are often detected in radiology by the presence of something that we do not expect to find, or alternatively by a change of the appearance of one or more of the organs in the body. For instance, if there is a cancer in the liver, that part of the liver affected by the cancer may be less dense, in other words darker, on a CT scan than the rest of the liver. Whilst radiology can detect lumps in the body, this does not tell us exactly what the nature of these lumps are, and you will often hear discussions about biopsies and histology. Biopsies are samples of tissue taken from the body, either from a lump that can be felt or using imaging, for example CT, ultrasound, or plain radiography, to guide a special needle that can sample some tissue in the body. That tissue can then be subject to evaluation down the microscope to see what kind of cells are there, to see whether the cells are normal or if there are features to indicate that this is a cancerous lesion. For most patients, ultimately the diagnosis of cancer is only provided by histological or microscopic evaluation of tissue, which is either removed by a biopsy or by surgical excision. There are, however, some circumstances where it is too difficult or hazardous to remove tissue from the body. And in these somewhat unusual conditions, we rely on radiology simply to demonstrate a pattern that we recognise as highly likely to be cancer, or for which there is no other satisfactory explanation. Imaging is commonly used to stage cancers. The staging of cancers is important to guide the correct treatment, but also provides information on the likely effectiveness and outcome of treatment for that individual patient. Information from lots of patients with cancer has shown us which aspects of a cancer are most important in determining what that cancer is doing and what treatment is best, together with showing what the likely outcome from that is. The staging of cancers tends to be somewhat specific to that particular cancer site and is based on the collected information of many patients. There is, however, a common pattern to describe the imaging staging of cancers, which is based on the system called TNM. This is where each cancer is described in terms of T for tumour, which is the size and position of the tumour. It also considers involvement of any adjacent important structures. We then go on to look for regional spread of that tumour, which is commonly through the lymphatics into lymph nodes, and N stands for nodes. If there are abnormal nodes which we think are present based on the fact that the lymph nodes are enlarged or have changed their appearance, we would like to try and describe where these are and the size and extent of the lymph node abnormality. The final aspect of the TNM classification used to stage tumours is to consider M, or metastatic disease. Metastases are tumours that have spread beyond the site of the original tumour, beyond even the local lymphatic system, and have spread either through the lymphatic system or through the bloodstream, or very occasionally through other methods to parts of the body far away from the original cancer. Common sites for metastatic cancer include the liver and the bones, but essentially all tissues in the body can be affected by metastatic disease. In the staging classification of a tumour using the TNM classification for each tumour site, there is often a number allocated to that tumour that depends on the measurement of the size, the number and location of tumours. For example, when discussing a lung cancer, it might be labelled a T2 lesion. This describes the size and position of the primary tumour. An N1 or N2 lesion describes the number, site and appearance of lymph nodes. An M0 or M0 cancer has no demonstrable metastatic tumour, whereas M1 identifies that at least one metastatic tumour is thought to be present. For instance, some cancers are staged based on the findings at operation, and sometimes this kind of staging describes more about the local effect and potential local spread of tumours. This information is also provided by histological or microscopical examination of the cells and tissues of tumours removed surgically. Staging of cancer is so important because it directs the best and most effective patient treatment for that individual cancer and helps patients avoid unnecessary treatments, which of course carry their own risk when these are of no benefit to the patient. The terms benign and malignant are sometimes used when describing cancers. These are somewhat old-fashioned terms that describe a tumour is very likely only to remain locally confined in the case of benign tumours, or tumours which show a much greater tendency to spread throughout the body, and they are often called malignant tumours. Sometimes people interpret this that benign tumours are not serious, but of course all tumours are potentially serious, and patients can die from benign tumours depending on the position and nature of that tumour. In some parts of the body, the concept of a benign or malignant tumour really does not have too much meaning, for instance in relation to brain tumours. Sometimes the words primary and secondary tumour are used. Primary tumour is usually in respect of what is thought to be the originating site of a tumour, for instance a lung cancer or a cervical cancer, as opposed to a secondary tumour which can be used synonymously with metastasis. It is possible, of course, that a patient can have more than one cancer, and it is not particularly unusual, for instance, with a patient who has cancer of the large bowel, to have another cancerous lesion within the bowel. For this reason, during diagnostic imaging, be it within the radiology department or the endoscopy department, staff are very careful to check all of the particular involved organ.